So let's get into some supratentorial craniotomies. So we've talked about skull base. Now we're going to move on to, the cerebrum. The tentorium is a tent-like covering of meningeal layers that separates the occipital lobe of the cerebrum from the cerebellum. So basically, this entire area, we're going to say it's supratentorial. Provides access to the frontal, temporal, parietal, and occipital lobes. Suture line located just behind the hairline. So anytime we're doing a surgery in this area, we're supratentorial. So one of the surgeries that you might be in is to monitor for a patient that's undergoing surgery for like a type of glioma, for example, like a glioblastoma. And these are brain tumors that grow from glial cells, and glial cells are support nerve cells with energy and nutrients and maintain the blood-brain barrier. There are different types of glial cells, and each one has a different function. A glioma is an umbrella term that's used to describe different types of gliomas, such as an astrocytoma or a glioblastoma, for example. Gliomas vary in their aggressiveness and malignancy. Some are slow growing and curable, and others are fast growing and not curable. The modalities that we're going to really look at for these types of surgeries are going to be SSEPs, motor evoked potentials, sensory motor localization, so that's using phase reversals or direct cortical stimulation, EEG, and electrocorticography. Another type of surgery, another type of tumor that we might kind of engulf in the supratentorial world is meningiomas. And meningiomas can be found anywhere because they grow off the meninges, but you might find them in these supratentorial. You might find them in posterior fossas. So again, the modality really depends on where the meningioma is. But we're talking about supratentorial, again, we're talking about, depending on where it is, we're talking about SEP, MEP, direct cortical stimulation, phase reversal, EEG. Another type of supratentorial surgery that you might be involved in is surgery for epilepsy. Have any of you ever done surgery for epilepsy? Okay. So basically, here they're not looking for a tumor, they're looking for the driver or the focus of the epilepsy. So basically, these surgeries are performed to treat seizures that are uncontrolled with medication. Epilepsy surgery, the idea is to remove the seizure, the area producing the seizure. So they actually will resect parts of the brain for this. They also want to limit the spread of the seizure. And it could be considered a curative procedure where it stops it, or it's a palliative procedure where it just restricts the spread, where you're able to stop it from going further. You can have curative procedures such as lobectomies, cortical excisions, where they do like subpeels of the cortical layers. You can do a hemispherectomy. I've been involved in those where they take the entire hemisphere. And the idea behind that is to completely remove the focus of the seizure, trying to keep dysfunction down. Now, obviously, if you do hemispherectomy, you're going to have some type of dysfunction on wake up, but sometimes that's all they can do. I've never been in follow-up. That's the one thing about our job is that we don't, Rusty asked, what do they do? Do they leave everything out? And honestly, one thing about our job is that we don't have that kind of follow-up, Yeah. So as Abraham says, it fills the space, I guess, and So basically what a seizure is an abnormal electrical discharge in the brain. This short circuit can cause change in behavior. It can basically, without you being aware of what's happening, partial seizures arise from one part of the brain and include simple, partial, and complex partial seizures. Generalized seizures involve the entire brain and include generalized tonic-clonic, absence, myoclonic, tonic, and so those are like your grand mal type seizures. Because you can have seizures without actually, having motor issues. Basically, a temporal lobectomy is the most common surgery for people with a temporal lobe epilepsy. It removes a limited part of the anterior temporal lobe along with the amygdala and a portion of the hippocampus. Temporal lobectomy leads to a significant reduction or complete seizure control about 70 to 80% of the time. Memory and language can be affected if this procedure is performed on dominant hemisphere. So if it's a left-sided issue, you can have language issues, and we'll get into language mapping for that. Cortical excision is the second most common type of epilepsy surgery. It removes the outer layer of the cortex of the brain at the seizure focus area. Basically, 40 to 50% of patients have better control of their seizures with this type of excision. And then a hemispherectomy involves removal of the brain's outer layer, an anterior temporal lobe on one half of the brain. It's usually performed in children who already have damaged hemisphere and intractable seizures with weakness on one side of the body. Seizures are controlled in about 80% of these patients. With surgery, many patients improve cognitive function and attention span and behavior after that is done. So when you do an epileptic surgery, there's a lot of brain mapping involved. EEG on the brain, electrocorticography, may be necessary if the seizure focus can't be located with standard EEG or other diagnostic tests. These diagnostic surgical tests use subdural grid electrodes or depth electrodes, depending on where the seizure focus is. Sometimes just having these subdural electrodes sitting on the outer portion of the brain can't find the driver of the seizure. They need to get more specific, so they use these depth electrodes they put into the brain tissue. Like I said, subdural electrodes, these are the typical grid electrodes that we've all seen. So the modalities that we use, again, in cases like this, SSEPs, MEPs, both transcranially and transcortically, direct cortical motors, EEG, electrocorticography, sensory motor localization, and possibly speech mapping if you're doing it for the temporal lobe. This is from a case that I did a few years ago. You can see this is actually a 64 grid with a 2x8 grid. So a 1x64 grid and a 2x8 grid next to each other. Here it is. Yeah. Here's a 2x8, here's a 64. So we'll talk about cortical mapping. So really, what you're doing when you're doing a phase reversal is sensory motor localization. We all call it phase reversal, but I like to get away from that type of language because sometimes you're not looking for a phase reversal. Sometimes your whole purpose of being there is to not get a reversal at all. So I like to say sensory motor localization. Then there's direct cortical stimulation. Now, there's two types of direct cortical stimulations. There's a type that you use in language mapping, where you use a bipolar probe and you stimulate for a couple of seconds and you take it off and you try to create an aphasia. Or there's a type where you use a grid electrode that you place on the brain and you stimulate with the same settings as a transcranial motor. You just reduce your current output. This could be used for two things, a direct cortical stimulation. It can be used for cortical mapping, helping to, find, it's also a sensory motor localizer, because you can use it to say, okay, I'm on motor or I'm not on motor. But it could also be used for functional monitoring. So just a caveat about using, how many of you guys have done brain mapping? Okay. So just a little caveat about when you do brain mapping, you should have the strip wet down prior to being placed on, subdurally. Usually they just have to dip it in the saline. It helps with the conduction. And ice cold saline should always be on the field when you're doing any type of cortical stimulation. Because if this person has an unnecessary seizure, they're going to want to mitigate it. And they do that by pouring ice cold saline.
So if the seizure doesn't stop, like what if it's just a short one? Or even if you see one, do it.
If there's two reasons you're cortical mapping, you can be cortical mapping for a seizure case, or you can be cortical mapping for a tumor. If you're cortical mapping for a tumor and you end up with a seizure, you're going to want ice cold saline there because you don't want the seizure.
Because that happened to us, and they were on anti-seizure medication, which apparently can actually make them more prone to having a seizure with stimulation. And so we did cause one when we were stimulating.
And did they put ice cold saline in?
No.
Why not?
But because it was short, I guess.
It stopped.
It was just very brief, but the anesthesiologist was like, whoa, what's something happening? So,
And then it was gone?
It was gone.
What? Well.
So, and we just didn't test the rest of the time because it freaked the surgeon out.
Yeah. Well, in that case, like I said, you have the ice cold saline. Say if it happens again, you maybe reduce your current. When something like that happens, you reduce your current, see if you can get it, and you have the ice cold saline. Because if you have the ice cold saline, if a seizure happens, they just dump it on and it goes away. So you can, so you can still map or monitor with a grid doing that. Yeah, cold. So sensory motor localization creates a phase reversal, and that phase reversal is going to be sensory or motor, and allows you to pinpoint the location of the sensory and motor cortices. So here's a central sulcus that's highlighted, and here's contact 1, 2, 3, 4, 5, 6. Okay? The idea is that if this is the motor cortex and this is the sensory cortex, you should get a big N20 response from 3 and 2, and you should get a big P20, give or take P22 response from 4, maybe 5, and probably won't get anything from 6 here in this situation. But the idea is that you get this phase reversal. That's when you're doing central sulcus mapping and locating. But like I said, sometimes the surgeon just wants to put the strip in and make sure he's not near any motor. You do a phase reversal, you end up with all sensories, and you never really do a phase reversal. You never get a reversal, and the surgeon's fine with that. So just keep that in mind. When you do a phase reversal, I do it from the median nerve. And it's no different than an SSCP. It sounds scary, you're putting a strip in, there's a lot of extra contacts. It's no different than doing SSCP. This strip just replaces your C3 or C4. So it's like recording 6 different C3s, for example. And that's really all it is. So you stimulate from the median nerve like you would any other median SSCP, whatever your stimulus is. Your filter settings don't change. Everything's exactly the same. You just set up your channels to be able to see, 6 inputs. And then you record from the strip electrode. Remember, it's contralateral stimulation, right? So if you're going to do, right-sided stim, you stimulate the left arm here. I'm sorry, right-sided acquisition, stimulate the left arm. And then you just reference it to FZ. That's no different than an SSCP.
But it doesn't take as long, right? It just instantly shows up, right?
Well, it depends. I mean, you run it. It depends on how noisy the room is. There's a lot of factors that come into play. You do need to average it out sometimes. Sometimes you have to let it run. But it's quick acquisition. It's just as quick as doing SSCP. And if you have good SSCPs, you're probably going to have a good phase reversal or a good sensory motor localization potential. So you get robust sensory responses are noted with a drop in amplitude occurring at the central sulcus and a phase reversal of the response seen in the motor cortex. So the evoked potential seen from the sensory cortex following median nerve stimulation is negative deflection with a peak latency at about 20 milliseconds. So it's N20. Followed by a positive deflection at about 30 milliseconds, P30. When you place that subdural electrode, you end up with this mirror image. So here's that N20. And guys, you can tell if you're not really sure about what your phase reversal should look like, look at your SSCP, because the morphology of your SSCP is going to be similar to the morphology of your phase reversal. On that patient, right. Where some look like amazing and some look like this. But you can definitely see, so here's N20, and then, now, it's like P22. It's not an exact replica, but it's within the same, area. So you kind of get the idea. So the sensory is here, strip 1 and 2, and then 3 through 6 is all motor here. That's what that's showing you there. The reason for the phase reversal, why it happens, like why do we get this mirror image when you're stimulating from the sensory, is not really fully understood. It's postulated that sensory impulses from the thalamus are being sent to the posterior wall of the central sulcus, and that the neurons within the prerolandic area are generators of the P22. So you're talking about prerolandic is the motor cortex. So they're saying that it might be just generated from that area. There could be association fibers from Brodmann area 3B influencing the generation of the P22, but it's most likely a direct projection from the thalamus to the motor cortex, and you get this reversal. So here we're looking at the thalamus and the central sulcus here. Again, we spoke about reasons to actually map the motor and sensory cortices. One's to obtain a phase reversal to differentiate motor versus sensory. The other one is to ensure the surgeon is not near the motor cortex at all. And I have one surgeon that likes throwing the strip in just to make sure he's not near motor cortex. We never get a reversal. He's just happy that he's not near it. And that's what you see here. So here, this is again the same picture, but it's showing you sensory and motor. This is a true phase reversal. Central sulcus is going to be between here. And then this is showing you no reversal, just some kind of weak sensories and then nothing. So they were probably way posterior with this strip placed, because you're getting some sensory and then you get flat lines. If you get some sensory and flat lines, it just means they're going more and more posteriorly with the strip. Where the one, like if we look here, like 1 might be here, and then 2 through 6 are going that way. Because if you go this way, right, with the strip, you should get a phase reversal.
So you tell me you might want to do this strip.
No, the way I've always done my mapping is I'd say, okay, I'm getting sensory responses. In this case, I'm getting sensory responses from contact 1 and contact 2, very little sensory response from contact 3, and the rest of them are completely flat. There's no response at all. Does that make, and I always say, does that make sense to you, to the surgeon? Because he's the only one looking at where he's placing it. And he'll say, yeah, it makes sense, good, we're away from the motor cortex.
What's the green on that screen?
Baseline.
Oh, okay, I was going to say, because that looks like phase reversal, right? Because you've got,
No, this is all sensory.
okay, even though you've got
This, I don't believe.
reversal of the.
No, this is all sensory. It's kind of going away.
The blue looks like it's going away. Like
Yeah, the
that.
blue went away too. Is that blue?
Yeah, the blue looks like it went away for sure, but the
Yeah.
green looks different.
Yeah, it's starting to go away. And it might, you know what, it might have been,
That would just confuse me. I'm glad I don't see that.
So, okay,
I don't remember this case.
this actually helped me out because I thought that, you know, whenever you're doing this, you're just looking for a pure reversal or whatnot, but
No.
no,
And then-
we can treat it as SCP and know that, you know, at this point when it comes in, that, you know, this would be sensory, or if we were just getting pure motor, I would know that this is pure motor because,
And also think your sensory, as long as you have your settings correct, your sensory response will always look like N20.
okay,
Will always be a negative deflection.
gotcha.
If you don't have your settings correct and it's reversed, it's going to mess you up. We always want to have the same. Positive deflection, motor. Negative deflection, sensory. And that way you know, and it can't be messed up. So you have to make sure your settings are correct. They should follow your SCP settings.
Okay.
So on the right screen, in the blue traces, you have more response and then it's really flat lines. So does that mean that that part of, I guess, whatever corresponding is closer to sensory? And then it goes
So
posterior?
this is the closest sensory, probably not even really
Not
clear
even-
sensory,
Okay,
but closest to sensory, and then it just goes away.
farther and farther away, so it's farther, okay.
And
Yeah.
maybe this is a case where, I don't remember this case, honestly.
Where the blue,
And I don't
where you are
have,
right there, it all looks the same, but when you go to the right, that's what was confusing me.
yeah, well,
Right.
I always like to get a baseline too. I'll always save a baseline. You don't have to. I mean, that's just me. I like getting a baseline knowing that I have it. But yeah, you cannot save a baseline and keep it an open screen. But basically, I'm sorry. When I'm talking about the response, I'm talking about the blue response. Blue response is sensory, and then it just goes away. And basically, what that is this is the closest to the sensory cortex, but you're not getting a big robust response here. But again, you have to look at your SCP. If your SCP looks like that, then maybe that is the response. So just keep that in mind. And just correlate the surgeon. I always say, does it make sense to you? Does what I'm telling you make sense? Because if he goes, no, 2 is definitely motor, then something's not right. Because in the way I do it, that can never be a motor in my world. And you don't want it to be. You don't want to be second guessing your setups in these kind of cases. These are functional cases where you're directing that surgeon on what he's going to take or not take. So you just want to be on top of that. So again, here's a setting. Sensory motor localization is just an SSCP. It's recorded directly from the brain. That's it. No different. Strip electrode replaces your C3, CZ, or C4 electrode. So depending on where that and what you're stimulating and where that strip is. Stimulus is delivered to the median nerve at the wrist, and it's referenced to FZ. No different than any other SSCP. So if you're going to set up a phase reversal in your protocol, all you have to do is copy your, in the Cadwells, all you have to do is copy your SSCP settings over, and then just add your acquisition channels correctly. But your settings should be the same. Filters should be the same. Everything should be the same. Stim intensity, wherever you guys are comfortable, anywhere between 25 and 35 milliamps as needed. You can do 200 to 1,000 trials, depending if you need to, average it out. Your duration, again, no different than a regular upper extremity SSCP, 200 microseconds. So there's nothing different in doing a sensory motor localization with a phase reversal as it is as an SSCP. And then a rep rate, whatever you're using as your rep rate for your SSCPs. Just, not divisible by 60. The other side of mapping is direct cortical stimulation. And basically, there's 2 ways to do this. There's bipolar stimulation, and this is most common in awake craniotomies. And then there's monopolar stimulation. And the monopolar stimulation is used in patients that are undergoing, under general anesthesia. Again, this can be used to differentiate motor and sensory, because you can stimulate with a bipolar the sensory cortex and you don't get a response. stimulate the motor, and you get a response. Or you can do the same thing with the strip. You can move the strip around. What's nice about the phase reversal is that if you don't get a response, like if you try to do a motor response from the sensory cortex that don't get anything, is it a true event not occurring, or is it a technical failure? So doing the phase reversal is nice to have, because okay, this is where the motor should be, and then to double check, the surgeon might put the strip over the sensory cortex and stimulate and get nothing, just to make sure. That makes sense. You can use this to map out the homunculus. So not just differentiating sensory and motor, but actually saying, okay, here's where the hands are, here's where the feet are, here's where the face is. And this is important depending on where the tumor is, or if it's epilepsy, it's important to know, especially if you're working right around the area, how is the homunculus laid out? Not everybody's the same. We know in the textbook it's, feet in the center, then go out to the face, right? But not everybody is built the same way. So, and it doesn't look like this through a hole that big, right? I mean, they don't make big holes, and they don't see all this. There's blood, so they can't see everything. It can be used to create aphasias, as I said, if you're doing language mapping. And that could be for sensory and motor. So you can create a Broca's aphasia, which would be a motor, or you can do a Wernicke's aphasia, which is more of a sensory type issue. And then it can also be used to monitor the functional integrity of the pyramidal tracts, as well as perfusion to the motor cortex. So that takes you out of mapping and puts you into monitoring. You can leave the strip on the brain if they're comfortable, if the surgeon's comfortable, leave the strip on the brain, and then instead of doing your transcranial motor potentials, which you need so much more current, and they might be bucking and they're in pins, you can just hit them with a low current direct cortical stim. Again, the settings for this is no different than your MEPs. It's just you're not going to stimulate at 100 volts. There is a difference, though, or 1,000 volts for that matter, but the only difference with the Cadwell machine is because it's a voltage machine for the MEPs, you have to set up your direct cortical stimulation in an ES9 channel. It can't go through your motor box. It puts out too much current. So you have to set it up and turn on the multi-stim. And you set it up like a train of 7 or a train of 9, or however you do your MEPs, but it's got to be in your ES9.
Would you plug it in the low? Like instead of 1 through 8, you just plug it in the low?
Whatever you want.
I didn't know if that was.
If you wanted to.
What is it like 8 to 12 or to 20?
15 is up to 20. Up to 20, it wouldn't go over 20. That's the literature says.
Okay. And when you do the multi-stim on that, like what are you setting on?
So multi-stim would be the train would be 7. Your ISI might be 2. It depends on how you have your motor set up. So look at your motor settings and mimic that in the ES9. That's the only difference.